Pituitary adenoma. Pituitary adenoma stimulates the release of TSH that will one of the pituitary adenoma will one thing it can release TSH, which will stimulate the diffuse enlargement of the thyroid gland, uh, and also the increase in T4 and T3. The other thing it can cause is the prolactinoma, which is increase of prolactin, that can decrease the libido. Next is the adrenal medulla is stimulated by acetylcholine, and the adrenal cortex is stimulated by ACTH. And the granulosa layer, the first layer, which secretes aldosterone, it's stimulated by angiotensin 2. Next is acromegaly. Acromegaly leads to the hypertrophy of the articular cartilage, uh, so leads to the osteoarthritis and all that. DiGeorge syndrome is due to the maldevelopment of third and fourth pharyngeal and bronchial pouches, which will lead to hypoparathyroidism, which will lead to decreased calcium levels. DiGeorge syndrome is basically you have the T cell deficiency because of thymus hypoplasia. It's a DiGeorge syndrome is a maldevelopment of the third and fourth pharyngeal or brachial pouch. You will have the hypoparathyroidism, and also the thymic hypoplasia. So you have two things: hypoparathyroid, not thyroid. Okay, hypoparathyroidism and thymus hypoplasia. Next, we have the maple syrup urine disease. That's newborn with sweet smelling diaper urine, burnt sugar smell due to branched chain alpha ketoacid dehydrogenase deficiency. The enzyme is the branched chain alpha keto dehydrogenase deficiency. This leads to increased level of the branched chain amino acids, which are the leucine, lysine, and valine. So if you have that, you're gonna for the treatment you wanna restrict these three amino acids: leucine, isoleucine, and valine, and restrict these three branched chain amino acids in diet. Sometimes, as for treatment goes, you can give vitamin B1, which is thiamine, which is a cofactor for the enzyme. So it might increase the activity of the enzyme, but that's only sometimes. The next is the erythrocytes. They lack mitochondria, so can't use ketone bodies. So they strictly need glucose. Next, we have the GLUT4 is an insulin-dependent glucose transporter in the skeletal muscle and adipose tissue. And GLUT1, 2, 3, not 4 but 5 are always present on plasma membrane, and they are insulin independent. So skeletal muscles, which is the majority bulk of the human body, and also the adipose, they require insulin for the glucose uptake. The rest of the body, you got the brain, you have the sperms, you have what else you had? All these, the rest of them, cornea, these things, they don't require insulin. They have other receptors which don't require it. The next is normal HbA Normal is the hemoglobin A. That's a normal delta hemoglobin. HbA2 A2 now, that's in beta thalassemia. Beta is 2, HbA2 is there. HbS is sickle cell, and HbF it is in the fetus. Okay, and this is also increased in HbF is not only increased in the fetus, but abnormally it is increased in the thalassemia major, all the big guns, the major, and the sickle cell disease, not the trait. So you have the thalassemia major, beta thalassemia major, and the sickle cell disease. The next is the, well, actually, it's the same concept here. One thing, the HbA1c are misleadingly low in hemolytic anemia. HbA1c is misleadingly low in hemolytic anemia because there is a loss of blood. Insulin, the next is insulin that acts on the tyrosine kinase receptors, leads to stimulation of two things simultaneously. First of all, it stimulates the tyrosine receptor that leads to stimulation of the RAS MAP kinase, and also stimulates the PI3K, which stimulates the protein phosphorylase and all that. So, uh, so normally what we have is we have the GS proteins and GI proteins. GS stimulates the adenylyl cyclase, leading to increase in cyclic AMP, which goes and stimulates the protein kinase A. GI, since it inhibits all of this, so here the GQ you all had AAA, adenylyl cyclase, cyclic AMP, protein kinase A. GQ on the other hand is C, phospholipase C, IP3 and DAG, protein kinase C. Okay. Next, we have the damage to the posterior pituitary leads to transient DI, which is diabetes insipidus. Damage to the hypothalamic nuclei leads to the permanent diabetes insipidus. Why transient when you are damaging the posterior pituitary? Because the ADH and oxytocin, they're not coming, they're not formed into the pituitary. They are formed from the hypothalamus, and then they are traveled down the pituitary. So if you have a damage to pituitary, it doesn't matter because it's still gonna come out, and somehow it's gonna find its way to the blood and gets released. The next is the congenital hypothyroidism. Hypothyroidism is going to cause, it's called the cretinism. You would have increase in TSH. It's a hypothyroidism. So you will have decrease in T4, decrease IQ of the person, and you will have 6 Ps. The pot belly, the protruding face, the protruding tongue, and all that. On top of that, you will have a neurocognitive dysfunction because the brain development needs the thyroid, and 6 months mother thyroid is more than enough. But after 6 months, we definitely need it. If levothyroxine is not administered, immediately that leads to neurocognitive dysfunction. The next is the exogenous levothyroxine, which is T4, that decreases the TSH, increases the T3, T4, and decreases the thyroglobulin. Thyroglobulin is a molecule that 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 is formed within the thyroid. uh, you know um, so so when you're giving exogenous, for sure you will have decreased thyroglobulin, because you're giving exogenous, not internally. It's T3 T4 not secreting internally. The next we have the PCSK9 in PCSK9. These two goes to the LDL receptors and leads to lysosomal degradation of them. That's the normal, that it causes LDL receptor degradation. So it is inhibited by PCSK9 inhibitors, which are evolocumab, alixocumab. They prevent LDL receptor degradation by lysosomes and increases the LDL uptake by sorry, let's get back there. So we have the PCSK9 inhibitors that's going to inhibit this, then which will lead to prevention of the LDL degradation by lysosomes. And it will lead to increase in LDL uptake by liver, leads to decreased serum LDL levels. Amazing. Next, we have the congenital hypothyroidism. Again, asymptomatic at birth due to maternal T4. After it wanes, the patient develops signs and symptoms, which is the flappiness, hypotonia, lethargy, constipation, umbilical hernia, large anterior fontanelle, and macroglossia, pot belly, protruderant tongue. Next, we have the anterior pituitary is derived from the pharyngeal roof called Redke's pouch. In children, the remnant of the Redke's pouch can lead to craniopharyngiomas. It's a solid, cystic, calcified tumor machinery oil liquid. That's craniopharyngioma. In adults, most common tumor of anterior pituitary is prolactinoma. Both craniopharyngioma and prolactinoma can give us the same sign and symptoms. Next, we have the increase in. Next, we have the primary adrenal insufficiency, which is going to lead to increase in acetylcholine. Not acetylcholine, but ACTH. So again, we have the primary adrenal insufficiency. If that means the primary means the insufficiency is within the adrenals, that means it's a regulatory hormone, which is the ACTH coming from anterior pituitary, is gonna increase and increase and increase. This will lead to, so because you have the primary adrenal insufficiency, no matter how much you increase the ACTH, so you will have decrease in all the layers, GFR, decrease in aldosterone, decrease in cortisol, decrease in androgens. Uh, then we know when you have aldosterone, when you have decreased cortisol, there's a decreased epinephrine release, which leads to the norepinephrine gets released due to stimulation by the ACTH. The next thing we have is if you have decreased aldosterone, this leads to decreased sodium, leads to hypovolemia. This leads to stimulation of the ADH and lead to water restriction. Okay. Next, we have the SLE. SLE, where we do treatment of the glucocorticoids, which can lead to iatrogenic Cushing syndrome and bilateral cortical atrophy, bilateral cortical atrophy for the fasciculated and reticulated zone only. SLE in the Cushing's can lead to increased acute coronary syndrome. Next, we have the FSH stimulates the Sertoli cells, which leads to formation of inhibin B, which leads to inhibition of the FSH as the negative feedback. LH, LH stimulates the Leydig cells, which leads to testosterone, which inhibits the LH and FSH, LH and GnRH secretion. So Leydig is more powerful. Lady is more powerful. Lady needs testosterone. That's why you have the testosterone. LH, L, lady, L, lady, testosterone. Well, lady is powerful. Forget the testosterone at the moment, but lady is powerful, and powerful people need testosterone. So here you go. It inhibits the not only the LH but also inhibits the whole axis, which is the GnRH. Next, we have the treatment for the weight loss. We can give sympathomimetic drugs, which are increase in our sympathomimetic weight loss, or the increase in norepinephrine release. For example, we have the phentermine, benzphentamine, and diethylpropion. Sympathomimetics, which is increasing the non-epinephrine release. Then you have the orlistat that can lead to inhibition of the intestinal lipases. At the next line, we have the bupropion or naltrexone. One is the antidepressant, the latter is the opioid antagonist.